Hello, Wayne County Community College students. We're back trying to finish up all this information that we have to learn about the heart. Heart is a big, big subject. There's a lot going on with it, and we just have to plow through it. Today, though, we're going to talk about the conduction system, the electrical conduction system of the heart. And let's jump right into it. The conduction system is modified because usually cardiac muscle is concerned with contractions. But modified heart muscle is concerned with electrical conduction. So that's totally different. So this heart beating, yes, that is the contraction part of it. But you need an electrical signal to even start that. Okay, so to even start the pumping, you need the electrical conduction. So let's see how we get that. So sinoatrial node is also known as the SA node. This happens to be the pacemaker for the heart. Usually our heart at resting beats between 72 to 75 beats per minute. Beats per minute, BPM. So this little squiggly line means approximately 72 beats per minute, but we'll say 72 to 75. It spontaneously discharges impulses. The sinoatrial node is located in the right atrium near the superior vena cava. So fortunately, it spontaneously discharges. We don't have to think about our heart beating. It just will get the signal, this electrical signal, and start to, the pulses will start to beat. Atrioventricular node, also known as AV node, sits in the right atrium along the lower part of the interatrial septum. So the AV node is in the right atrium between the two atria, in the wall of the two atria, in that septum. Atrioventricular bundle, also known as the AV bundle, but we also can call it or refer to it as the bundle of His. That's the way I learned it. HIS is not his, it's like it, like a cat hisses. So it's the bundle of His. This is in the right, left and right divisions down the interventricular. Now you're in the ventricle part. Up here is in between the atria. Here is down below in the ventricle part, interventricular septum. I need you to understand that this AV bundle or bundle of His is the continuum. It's a continuation of the AV node. This is a continuation pushed down from the atria now into the ventricles, and it is a continuum or continuation of the AV node. Purkinje fibers run along the borders or the outer borders of the ventricular muscle. Let's take a look at all of this and see if we can get a visual on it. So let's draw our heart. And let's draw the chambers that we know of, right? So let me put the veins in here just so for reference. So we know that this is the right atrium, and we know that's the right side of the heart. So the SA node sits here, located in the right atrium, just near the superior vena cava. So it is just a little node of tissue. The AV node is in the right atrium, in the lower part, in the interatrial septum, about right in here. The AV bundle or bundle of His is a continuation of this AV node, and it sits about right here. And then you have the Purkinje fibers running along the outer edges or the lateral borders of the ventricle. So SA node, AV node, AV bundle, and then here and here, I'll just say those are the Purkinje fibers. Okay? So it's going to go from SA node to AV node to AV bundle, and then here along the ventricles. It's really hot. I know that I'm perspiring, but it's really hot. I want you to know that being in this lab jacket, it's burning up. But here we are, and we can see how the electrical signal goes from this pacemaker to the AV node, to the AV bundle, also known as the bundle of His, and then it propagates out along Purkinje fibers. What do you think is the signal that actually starts the AV node? What startles or what gives the AV node information to know how to make the heart beat, or how fast or how slow, what pace to make it? Since the SA node is the pacemaker, how does it know that, oh, at resting, we're going to be, at 72, well, at resting. Or, okay, we're exercising now, so we need to be at 120, for example. Well, we have something called a cardiac plexus, or plexuses, let's say. And we have something known as a sympathetic. This is an autonomic nervous system, the same kind of autonomic nervous system that is in the muscle of the tunica media. Remember, we mentioned that before when we talked about blood vessels. Here, though, you have a sympathetic and parasympathetic system. The sympathetic system, of course, is the one that speeds things up. It is like the accelerator, right? This is and this one is the parasympathetic. It's more like the brakes or the decelerator, we'll say. I'll just put brakes. Slows things down. And this is fight or flight. Okay? So, say we're sitting and just relaxing, and I'll just give this example. Let me just start over. So I'm walking down the street, just mind my own business, but the hairs on the back of my neck stand up because my body, even though I can't see it, something's telling me that something is encroaching on me, something is harmful could potentially happen to me. And I turn and I see this dog coming after me. I don't want to demonize any dog, but usually I use a Rottweiler or something like that, but I don't want to demonize any dog. But so a dog, we'll just say a dog is coming after me. And he's looking vicious. And I'm like, oh my goodness, what is going to happen? So immediately, me seeing that, my pupils dilate and I'm looking around, I'm trying to see is a door open somewhere, like a car door, somebody's home door? Is there a fence I could jump over and get away from this dog? Is there a tree I could climb up? Is there any way that I could possibly get away from this dog? Well, of course, initially I start to run, right? Because that's just your initial instinct when you see something harmful about to happen to you. But you have 2 legs, or I have 2 legs, and the dog has 4. So typically, that means the dog could run, twice as fast as I can. But I'm going to run anyway. But now my pupils are dilated, my heart is beating. This sympathetic system has come into the sinoatrial node here, and it is influencing my heart rate. My heart rate is up now. It's feeding blood to my legs and muscles so I can run. And I have to get away from this thing. Pupils are dilated because I need to be able to see far, and I need to be able to see what can I climb, jump into, close off, any way to distance myself from this dog, right? But the dog comes up on me, catches me. That was the flight part. I was running. So I take my keys out of my pocket and I start to stab him in the carotid because I know where the carotid is and the eye, etc. Now that's fight. So that's the sympathetic nervous system. You have fight or flight. Oh, I guess that should have been a T there. Yep. And I just start stabbing them with my keys and I'm safe. Okay? The dog is not, but I am. So that's fight or flight. You're gonna run initially, or you're gonna fight. And that's the sympathetic nervous system. That's one thing I never understood. You know those shows, cop shows, where I think they're bad boys, what you gonna do? Well, it's always this guy in some kind of t-shirt, you know, I don't know why they're always walking around in underwear. I don't know why they don't wear shirts. But they always have on these t-shirts, and the cops are like, halt, you know, or stop. And the guy takes off, and then the cop catches him, and as he gets him, tussles him down to the ground, he always asks, so why'd you run? And sometimes I just would like to stop everybody and say, he ran because of this. If the guy would just stop and say, officer, I ran because my sympathetic nervous system kicked in. I didn't really understand that you were a cop, or maybe I did. Maybe that is why I ran. But I just saw somebody with a gun or a baton or some spray or a taser or something that was pointing in my direction, and I was trying to save my life. So that's why I ran. I mean, of course that's why I ran. I would never get it when they ask, why did you run? Because I'm not going to stand there and that you hurt me. That's why I ran. Anyway, that's sympathetic. Parasympathetic, you're sitting on the couch, you're watching a nice movie, you're with somebody that you really care about, and that person really cares about you. It's really calm, your heart rate is low, you're relaxed, the movie is calm, and you're just eating your popcorn, enjoying your life. That's parasympathetic. These are the states too. Parasympathetic is when you can also, your gut can move, you can make bowel movement during parasympathetic. You know, things are functioning in your urinary tract and in your gut. You can urinate, you can poop. These are times when you have parasympathetic. You're trying to get your child dressed, it's winter, you're putting on the snowsuit, you say, Johnny, did you go to the bathroom? Yes, Mom, I went, I don't have to go. Johnny, go to the bathroom, I don't have to go. Okay. Get him on this whole snowsuit, zip him up, boots on, hat, going out to the car, you scraped off the car, he's sitting in his car seat ready to go. You backing out, and Mom, you have to go to the bathroom. Now you blow a gasket. What, didn't I tell you, Johnny, you had to go? And then he said, oh, I don't have to go anymore. Yeah, because you just took him from parasympathetic, he's nice and warm, sitting in this little cozy snowsuit, the car's running and it's warm, he scraped it all off, and he relaxed. He was parasympathetic. Yeah, he has to go to the bathroom now. But as soon as you start yelling at him and telling him, he went right to sympathetic and the whole system shut down. So this is how our system works. I don't want you to think it's either or all the time. We're not just functioning between these two. There's other things too that influence. But I do want you to know that these are some things that come in here. Parasympathetic, and sympathetic have a big influence on that pacemaker, that SA node, in that way, as well as our digestive system, etc. So you need to know this order. The SA node is the pacemaker, approximately 72 beats to 75 beats per minute is our resting state for our heart. It sends the signal to the AV node, to the bundle of His, and then to the Purkinje fibers. And so information comes into the SA node via, we'll say parasympathetic, sympathetic, shoots a message to a signal to the AV node, on down to the AV bundle of His, and that will have the Purkinje fibers contract the ventricles. So that is how we get blood to move along. I want you to know that the sympathetic is from the cardiac nerves, and the parasympathetic is from cranial nerve 10, and that's the vagus, not like Las Vegas, but the vagus nerve, okay? Vagus nerve, yep, that's cranial nerve 10, yep. So I need you to remember that. Parasympathetic, cranial nerve 10, vagus nerve. Whenever you think about the vagus nerve, think of things slowing down. Cardiac nerves will supply the sympathetic. Oh, yep, I do have another thing on here, ectopic pacemaker. Anytime something's ectopic, that means it's displaced. So you've heard of ectopic pregnancies. That just means that the pregnancy is not within the womb. It is somewhere other than the womb. It's somewhere other than the uterus. Usually it's in the fallopian tubes, or it could be somewhere else. But it just means that it's ectopic. It is displaced. So here we have a displaced pacemaker. For some reason, the SA node is not working. So SA node, for some reason, is unable to perform its duty, perform its job. Then it becomes the responsibility of the AV node or the Purkinje fibers to take over the duties of the SA node. For example, maybe you had a MI, heart attack, and it knocked out the SA node. Well, now where are you going to get the signal? The signal will come to the next best thing, the AV node, and the AV node will propagate and send the signal to the Purkinje fibers. I need you to know, though, that if it's not the SA node getting the signal, getting a signal from the outside, then to be the pacemaker, the AV node will kick in and start to take over the job. But the heart rate would be nowhere near 72 to 75 beats a minute. It would not be in the normal range. It's going to be much lower, about 40 to 60 beats per minute. 60 beats per minute can be normal in well-trained, well-tuned athletes like Olympiads. They have a 60 beats per minute heart rate. Other than that, yogi masters can make their heart rate go down low. But usually, regular people like you and I, a heart rate of 60 is going to be too low. That is going to be too low for us. Unless you're a yogi master or a really tip-top conditioned athlete, a 60 beats per minute heart rate is not going to be a good functioning heart for you. So that is what I wanted to say about the introduction here of the cardiac system, conduction system. We will get into EKGs and look at some P waves and stuff next. All right, so let's go on and start talking about electrocardiogram. All right. I learned it as EKG, but now everybody calls it an ECG, whichever, they're the same thing. So the E, the C, and the G, electrocardiogram, is really an output of a drawing, if you could say that, of the electrical current, that the way it's going through the heart. So let's give a definition. This is a record of the electrical activity of the heart. Note, it is not a record of the heart's contractions. It's not a record of the heart's contractions, but it is of the electrical events that precede them. So EKG is showing the electrical events that come before the contraction, all right? So it's like, let's liken it to, you have bread in a toaster. So you want toast, right? But you have to send the electrical current. The electrical current must go into the toaster. You know, you press down the bread to get it to become toast. You must give the electrical current to it before it becomes toast. So before you get a contraction, before it pops up, we'll call it the contraction, you must send electricity to it for it to become toast. So the electrical activity is shown via an EKG. That electrical signal comes before the contraction. So the electrical signal can actually help propagate a contraction. So let's look at just a standard type of EKG or ECG. The first wave that we see here, this is a P wave. This is a P wave. P wave. This represents atrial depolarization. So the atria are contracting. So we'll use the word depolarization as a very kind of light way of calling it a contraction. Then we have the QRS. QRS is actually, this is called a QRS complex. QRS complex has two things in it. It has the atrial repolarization, when the atria now relax, and then it has the ventricular depolarization, where the ventricle contracts. So this complex, this QRS complex, has two things kind of masked in this complex: the atrial repolarization and the ventricular depolarization. Next, we have the T wave. The T wave is the ventricular repolarization. So here you will see the atria depolarizes in the QRS, the atria repolarizes when it relaxes, then the ventricle depolarizes where it contracts, and then the ventricle repolarizes where it relaxes. Now there is something called a U wave. I won't really talk about that or get into that. We don't usually talk about that, but there's some little U wave, and that's really where the Purkinje fibers repolarize. But we're not going to even talk about the U wave, so I'm just going to take that off. I just wanted to mention it just in case you saw it somewhere. But that U wave is the repolarization of Purkinje fibers. It's sometimes seen. Let's go then and look at EKGs, and let's see what we can tell about. Now, I used to read a ton of these, but now you don't have to know how to read them, because you go get an EKG, the machine will spit out it'll read it for you. You don't have to learn how to read it. But it's on grid paper. I used to have to, you have to know what each little square within a square meant, and look at the millimeters per second, whatever. But now you don't. So let's look at a normal. We're going to call this a normal EKG. You can see the P wave, the QRS, then the T, then the P wave, the QRS, and the T. Now for me, when you're reading these, some people look from P to P to P, but I usually take the highest peak and I go from R to R to R. And I just eyeball it, and I can tell that, okay, this looks like a pretty good, distance between them, R to R to R. And so I know that's normal. That looks like about 72 to 75 beats a minute. When you look at enough of them, you can tell. This one, on the other hand, and we'll go R to R. You see how far this R is to that one? It took a long time to get there. This is a much slower heart rate. We call this bradycardia. You have bradycardia when your heart rate is less than 60 beats per minute. So normal would be about 72 to 75 beats per minute. And we're saying this is at resting. And resting for bradycardia, this is less than 60 beats per minute. This is a long distance from R to R. Now let's look at this R to R to R to R. You see how fast and quickly these R's are coming up? Boom, 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 boom. This is tachycardia. This is a heart rate at resting that's greater than 100 beats per minute. So you can eyeball it. Once you know what normal looks like, which we would say this is the normal one, you can compare them to the bradycardic one and the tachycardic one. Now this is the one that you need to avoid at all costs. That one. That is called asystole, asystole, or, in layman's terms, flatline. You see no P waves, no R waves, no nothing. That's the one you don't want to see, because that means you're dead. No heart electrical activity, right? Okay. So this is really, so that's the one, so we know that this is too slow, that's too fast, and that's just right. Little Goldilocks there, right? All right. So that is everything that I kind of want to say about this. I just want to go over, you must remember things like this. If we talk about the P wave, you must know that that is the atria depolarizing, and then the atria must relax. Let me put it to you this way. When there's depolarization, that means that there's filling, the chambers are filling with blood. When the chambers are filling with blood, the heart, that part of the heart must be relaxed. When you see when you see repolarization, when you see repolarization, the heart is relaxed. When you see depolarization, that's a contraction. That's when the muscle is pushing out the blood that you just filled it with. All right? And you must contract, then the atrium must relax, then the ventricle contracts, and then the ventricle relaxes. So it's a contraction, a relaxation, a contraction, a relaxation. Take care of the atria first, then take care of the ventricles. And that way you will remember it. So if I ask, what is the P wave conducive, or what does the P wave represent, or is it indicative of, you can say it's atrial depolarization. If I say, well, what is this big complex, the QRS? You must mention the two things, both things, atrial repolarization and ventricular depolarization. If I say, well, what is the T wave? You must say ventricular repolarization. Make sure you get the repolarization and the depolarizations absolutely clearly correct in your brain. Okay, so next time we will go over the cardiac cycle and look at some baroreceptors, I guess, and some chemoreceptors. Yep. So we're going to go over some, finish up some more like physiology. We did most of the anatomy, now we're just getting into the physiology. So we'll come back and look at the cardiac cycle. All right, so let's go on and talk about the cardiac cycle. Cardiac cycle means a complete heartbeat. Complete heartbeat would be a contraction, and that is systole or systole, with relaxation, and that's diastole or diastole, of both the atria and the ventricles. So, like I said, when there's a contraction, that really is another way, or systole, you could say that is ejection. Blood is being ejected out. When it's relaxation, or diastole or diastole, that is the filling. The blood is filling the ventricle or filling the atria. When it's contraction or systole or ejection, the atria are ejecting the blood out of it, or the ventricles are ejecting the blood out of them. So remember, the two atria contract simultaneously, then the atria relax. So the two atria that are on top, they have depolarization, or they contract, and then they repolarize and relax. Both ventricles contract and relax instead of the heart contracting as a unit. So let me see if I can demonstrate this. So you say the atria on top, right? The ventricles at the bottom on the lower aspect. So here they're going to do opposite. The atria, when it is closed like this, they're squeezing, they're contracting, they're pushing the blood into the ventricles. At this point, the ventricles are filling with blood. Then the ventricles contract and the atria open up and relax. And they're filled, now the atria is filling with blood. When the hand is open, it's relaxed, so it's filling with blood. When the hand is closed, it's contracting and pushing the blood out. So the atria is on top, the ventricle is at the bottom. And this is the way it goes. right? The atria are filling, the ventricles are contracting. The atria are contracting, the ventricles are filling. They don't go at the same time. If they did, you would need to defibrillate. You have to get the paddles and defibrillate the person, because that would be the heart is not contracting properly. It is opposite, like this. Because the ventricles have to be open in order to fill, in order to get the blood in them. And the atria must relax because they're going to have blood coming in from the veins. Superior and inferior vena cava on the right and the pulmonary vein on the left. So it can't get blood in it if it's contracting, right? So it must repolarize, relax, blood will come in. The ventricles must be ready to receive blood when the atria depolarize, and they push the blood through the tricuspid and mitral valves, and now the ventricles will fill, and that will be diastole. Then they'll contract and send the blood out of the pulmonary artery and the aorta, and now the atria will fill again from the veins. So it goes like that. So just remember that aspect of how the atria and the ventricles use contraction, systole, and ejection. Those can all be used real loosely. That's the same thing. Relaxation, diastole, and filling can all be used, okay? So it doesn't beat as one unit. That would, it goes so fast it looks like it's beating as one unit, but they're not both. The atria is not filling at the same time the ventricles are, and the ventricles are not contracting at the same time the atria are. So let's look at this cardiac cycle. It's in your book. It looks a little different than this, but this is the way I learned it, so I'm going to teach it this way. It's the same concept. Always look at your axes, your Y, your X axes, and then always read it. So this is pressure in millimeters of mercury, that's mmHg. I didn't have to write it sideways like that. It might be hard for you to see. But this is pressure in millimeters of mercury, okay? That's the way pressure is read, in millimeters of mercury. Remember that because we're going to go over that again when we get to respiratory. Millimeters of mercury. Then here is the volume in milliliters, ventricular volume, and that's a fluid or liquid, so that's in milliliters. And this is showing the ventricle filling. Now, when we talk about the heart, for all intents and purposes, we just really talk about the left side of the heart. So really, this is the left side, but really whatever's going on the left side is also going on the right side. But for our purposes here, we'll just talk about the left side. So from 0 to 85 to 130, these are milliliters, and then the pressure is here, 20 millimeters of mercury, 40 millimeters of mercury, all the way up to 120 millimeters of mercury. And this is the cardiac cycle. So let's start here. Mitral valve opens. You know the mitral valve is on the left side. So the mitral valve opens. What happens to the ventricle? You have ventricular filling. Everything is going to start filling the ventricle from the left atrium, correct? All right. After you get it filled up so much, now you have about 130 milliliters of blood in the ventricle. The mitral valve closes. Boom, closes, all right? That closure there would be considered as S1. That's the sound, the first sound here, so sound 1. Along this axis here, this is isovolumetric contraction. Okay, isovolumetric contraction. So iso, the same volume, 130 milliliters, along this whole thing, along this whole axis, 130 milliliters. Same volume, that's what that means. And then you're gonna get a contraction, just a minute. Now the aortic valve has to open. Aortic valve opens because this mitral valve closed, aortic valve now opens. You get an ejection, the blood ejects out of the aorta, goes to all the tissues of the body, then the mitral valve closes. Not mitral, the aortic valve closes. That will be considered as S2 when that valve closes. And this is now, you're going to get isovolumetric relaxation. Same volume here, I don't know, you can make that volume like, I guess 25 or whatever, milliliters of mercury, right here. Same volume, volume, same volume, 25, we'll just say it's 25 milliliters there, because that's 85, so I'm just saying. So this is a sound 1, and over here is sound 2, S2. It's going this way, because you can tell that the ventricle is filling. Then it goes up this way, and then down this way. And it just keeps going around and around. Now that's just talking about the left side of the heart, but the same thing is going on the right side as well, right? All right, so let's look at this again. So here we are with the mitral valve opens, ventricular filling. You know, when the mitral valve opens, the ventricle can fill. The mitral valve closes. You have isovolumetric contraction here. When the mitral valve closes, that's the first sound you hear. Then the aortic valve opens. You get ejection. All the blood is going down the left ventricle. And then, of course, the aortic valve closes. That's the second sound you hear, S2. And then on down you get isovolumetric relaxation. And so same volume at relaxation, about 25 milliliters. Then the mitral valve opens again and the ventricle fills. So it just keeps going in a cycle over and over and over. Whatever is happening on the left side of the heart is also happening on the right side of the heart, but we just use the left side to give, to be more illustrative with it. All right, so we're going to talk more. Oh, and I wanted to mention that some authors call the first sound also isovolumetric contraction, but really it's the closure of the valve that's the sound. Some authors will say S2 is isovolumetric relaxation, but really it's the closure of the valve. In this case, the aortic valve closes. So let's talk about the valves closing so you can understand it more. Even though some authors talk about it in terms of the contraction. I don't know why that doesn't make sense to me. The valves closing makes sense to me, that you would hear it as a sound, but not the isovolumetric contraction. But okay, whatever. Heart sounds described as lub-dub. So when we are listening to the heart through the stethoscope, it's lub-dub, 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 lub-dub. The lub is S1. That's the first sound. The dub is S2. That's the second sound. So lub, dub, lub, dub, lub, dub, lub, dub, lub, dub. The first heart sound, and you have to remember, we're talking about the right and left sides of the heart now, would be the mitral valve and the tricuspid valve closing. So I know we put mitral valve closed here as S1, but remember, this is just the left side of the heart. You have two sides to the heart. So whatever's happening on the left side is also happening on the right side. And when the mitral valve closes, simultaneously, the tricuspid valve on the right side is closing. But it's heard as one sound, and that's the first sound. The lub sound would be the mitral valve and the tricuspid valve closing. So, say you have twins, and you got frickin' frack. You told them, hey, go upstairs to your room. And they're angry, so they go upstairs, they stump upstairs, and frickin' frack go upstairs, and Frick goes in his room and Frack goes in her room, and they close their bedroom doors at the same time, like this. Two doors close, but since they close them simultaneously, you hear one sound. That is what is going on here. The mitral valve and the tricuspid valve are two closures. That is true, but they're closing at the same time, so you only hear one sound, and that's the lub sound. That's sound one. Here again, the second heart sound, the aortic and pulmonary valves closure. That's the dub sound, the S2. So now you got frick and frack going upstairs, and they're going to each to their own rooms, and they go upstairs and they're angry. They close their doors. Frick closes his door, frack closes her door, boom. Same time, that's S2. That will be the aortic valve closing, but since that's on the left side of the heart, on the right side of the heart, that will be the pulmonary valve closing, right? And that will be the S2. So this is how it sounds in through the stethoscope, and these would be the actual sounds of the valves closing. But like I said, some authors will say it's the isovolumetric contraction or the isovolumetric relaxation. You know, we're not going to argue it. Just know where this is on which side of the curve and where this is on which side of the curve, and you will know which valve is closing, right? Heart sounds could tell the doctor if there's anything wrong with the heart, especially the valves. Heart murmurs can be detected this way, where they cannot or will not be detected on an EKG. So there's nothing like just taking a stethoscope and listening to the heart sounds and the heart valves closing to be able to hear what's going on. EKGs aren't going to really give you all the information you may need, but murmurs are detected through sound, right? I want to take a look at blood pressure. Greater than 140/90 is considered to be hypertensive or hypertension. That's systole over diastole. We know that the systole is the ejection of blood or the contraction. And we know that diastole is the relaxation or filling of blood. Anything over this, so systole over diastole, ejection over filling, you want to make sure that you keep that around 120/70 in that general area. Start getting any higher, like approaching this. If you're on if you get medication, please take it, because this can wreak havoc. This type of pressure wreaks havoc on the vessels. So you want to get your blood pressure down by eating very low sodium, trying to drink a tad more water, and really, if you smoke, to stop. And that includes marijuana. I don't know what this thing is about marijuana, why everybody thinks it's so great. It is not. It can still harden your arteries and still get lung cancer. Your lungs do not like smoke. I don't care how much you pay for it. All right, so we're going to come back and look at primary principle of circulation a little bit, and I guess we'll look a little bit at baroreceptors and chemoreceptors. And after we go through those few things, then that will conclude. Oh, I think it's one other thing we have to do. I think chapter 30 does talk a little bit about the angiotensin-aldosterone system. So I will go through that just to give you the words and so you'll understand it. I really talk more about that when we get into the kidney, but I will mention it here so you'll get an introduction to it. But we'll come back to that in a minute. All right, let's look at the primary principle of circulation. Primary principle of circulation. Blood flows or circulates the same as any fluid flows, just like any fluid, because of a difference in a pressure gradient. There has to be a difference in pressure in order for fluid to flow. This same concept is going to go for gases as well. So in other words, fluid and gases behave similarly. They both need a pressure gradient, a difference in pressure. Fluid does not flow when the pressure is equal. Fluid or gases, but we'll just stick with fluid since we're talking about blood, will not flow when the pressures are equal. Fluid flows only when the pressure is higher in one area. Always flows from an area of higher pressure to an area of lower pressure. and you need a pressure gradient. So a pressure from a higher pressure to a lower pressure, that space in between is the difference. So you need a difference in pressure in order for fluid to flow. When pressure 1 is equal to pressure 2, there's going to be no flow. So if I had an identical twin and we are built the same, everything about us the same, and she's pushing against me and I'm pushing against her, there's not going to be much movement. Actually, no movement, no flow, no movement, nothing. Because we both have the same strength, the same pressure. Pressures are the same, nothing's going to move, right? Here's pressure 1 is 20 and pressure 2, for example, is 15. We can see that there's a difference in pressure. They're not the same. So the pressure difference or the pressure gradient is 5. And you remember pressure is in what? Millimeters of mercury. Hg is mercury, right? So that would be a pressure gradient or pressure difference of 5 millimeters of mercury. Pressure 1, pressure 2. Which way will pressure go? Will it go from pressure 1 to pressure 2? So does it go from P1 to P2? Does it go to P2 to P1? Or what? It goes from a higher pressure to a lower pressure, so it's going to go from P1 to P2. Pressure 1 to pressure 2. Here is Fick's law to talk more about how we get, so let me just finish this. So arterial blood pressure is determined by cardiac output and peripheral resistance. Both are directly proportional to blood volume. In other words, pressure and volume are directly proportional. So pressure and volume are directly proportional. If you increase the volume, blood volume, you got to increase the blood pressure, right? You increase the volume, you increase the pressure. That's why eating salt, what happens when you eat a heavily laden salty foods, you increase your volume. Why? Because wherever salt is, water will follow. And water goes there to try to dilute all the salt. So any water that's in the body is going to follow and go towards where the salt is. What is that going to do? Increase your volume. When you increase your volume, what do you increase? Your pressure. And that's why the first thing a doctor will tell you to do when you have high blood pressure is to lower your sodium intake. You lower the sodium, you lower the volume. If you lower the volume, what do you lower? You lower the pressure, because volume and pressure are proportional to one another, directly proportional, all right? So let's look at Fick's law. Cardiac output equals stroke volume times heart rate. So cardiac output, this is the blood that's going out of the heart. And we'll say it's going out of the heart through the aorta. Cardiac output, what's coming out of the aorta is the blood from the left ventricle. Stroke volume, how much volume of blood is in that left ventricle when it contracts? How much volume is in it? How much blood is in there? And then of course the heart rate is your pulse, right? So in general, if the stroke volume is increased or if the heart rate is increased, then that will increase the cardiac output. So if you have a lot of blood, a lot of volume in the left ventricle, what's going to come out of the heart? A lot of blood is going to come out of cardiac output. It's going to come out of the aorta, right? And to all the tissues of the body. If your heart rate is up, that's going to increase your cardiac output. If your heart rate, if you're beating your heart faster, then you're going to have cardiac output. Blood is going to be coming out of the aorta faster. On the other hand, if you don't have a lot of blood in the ventricle, the stroke volume, the volume is low, then your cardiac output is going to be low. Say you're hemorrhaging, you don't have a lot of blood you don't have a lot of volume. So your left ventricle is going to have a little bit of blood, and you're not going to have a lot of blood coming out. Cardiac output is going to be low. Heart rate is real low. Your cardiac output, what's going out of the heart, out of the aorta, is going to be low. So these things are proportional. So in general, if you increase your stroke volume, increase your heart rate, cardiac output is going to increase, and vice versa. Decrease the stroke volume or decrease the heart rate, cardiac output is going to decrease. So, so that is really the gist of the principles of the primary principle of circulation. We're going to talk about arterial baroreceptors and chemoreceptors, and then try to wind it on down to the end of chapter, I think it'll be 30. So we'll get through a little bit of chapter 30 and call it that'll be it. All right, let's take a look at arterial baroreceptors. When you think of arterial baroreceptors, I want you to think about receptors that are sensitive to changes in pressure. These are sensitive to changes in pressure. When you see baroreceptor, think of pressure. So these receptors, you have receptors in the aortic arch. Remember the aortic arch? And in this aortic arch, I'll just draw the aortic arch. Let's just do that. Come on down. You have receptors in here. And why? Because that blood is coming up from the left ventricle, and you don't want it to like shoot up into the brain and blow your, put too much blood in the brain one time. So these receptors kind of, hey, slow things down a little bit. So they go through the vagus nerve. Remember that? Cranial nerve 10. And that was a parasympathetic, right? So this is going to slow things down a bit to the medulla, which is the, in the midbrain. And they respond only to an increase in blood pressure. So if it's too much pressure coming up directly from the aorta, these little receptors in here will say, hey, let's slow the roll. We don't want so much pressure up here. We don't want to blow a gasket, in other words. Carotid sinus transmits via the glossopharyngeal nerve, that's cranial nerve 9, and that also goes to the medulla. And the medulla kind of just, regulates your pressure. These nerves help regulate the pressure as it corresponds to the medulla. Let's put it that way. Here we have chemoreceptors. Here, these receptors will respond not to pressure like baroreceptors, but to the chemistry, chemo, right? So we have aortic bodies. These are in what? The aorta. Also, they're going to respond to decreases in partial pressure of oxygen, increases of partial pressure of carbon dioxide of the blood. So these are looking at chemistries, oxygen and carbon dioxide. These are the gases that we're mainly concerned with. So if you have too little oxygen and too much carbon dioxide, that is going to indicate a problem. A good example of that would be when a person has what is that called? Sleep apnea. Sleep apnea. When a person has sleep apnea, they're sleeping, but then they'll stop breathing. Apneic, meaning they stop breathing without breath. And then they breathe again. So what is that doing? That's sending a signal to the brain. Wait a minute. You have too much CO2 building up in the blood, and it's going to wake you up so that you breathe again. This can go on hundreds of times during the night. That's why these people are sleeping during the daytime hours when you're supposed to be awake. They haven't slept all night because throughout the night they stop breathing. The senses go off, and these chemoreceptors wakes them up. They breathe again. Then they stop breathing. And they breathe again. This can go on all night. Right? And this can happen until you get the CPAP, get the machine that's going to force oxygen into your system. So you will have a decrease in oxygen and an increase in CO2 that's going to build up when you stop breathing, and that is detected in the blood. The carotid body is a little different. Carotids, remember the carotids on each side of the neck? These have receptors and bodies in it that respond to also a decrease in partial pressure of oxygen, an increase in carbon dioxide, but I want you to remember that the carotid bodies look at pH. When you have a decrease in pH, that means you have acidity in the blood, acidic blood, a decrease of pH in the blood. If you have a lot of CO2, that is a sign of a lower pH, of acidic pH, particularly sensitive to increases in CO2. And I want you to remember that the carotid bodies are particularly sensitive to increases in carbon dioxide, and that's called hypercapnia. Hypercapnia. The chemoreceptors respond to the carotid bodies respond to changes in the pH and partial pressure of carbon dioxide of the brain, which in turn are influenced by the arterial carbon dioxide. So we really do look at carbon dioxide in the blood when we're looking at the chemoreceptors. Carotid bodies do also take into account a low pH, which means acidity. The last part of this, I believe this is chapter 30, we want to look at the renin-angiotensin-aldosterone system. When we look at the renin and angiotensin-aldosterone system, that system actually kicks in when the body, the pressure detects a low blood pressure. Now, usually we're not concerned about a low blood pressure, but there are instances when a low blood pressure is, a problem. A low blood pressure is a problem. But when will we get a low blood pressure? Well, you can get a low blood pressure if you're dehydrated, severely dehydrated. You can get a low blood pressure if you're hemorrhaging, you're losing volume of blood. Low blood pressure if you have a lot of emesis, you've been throwing up a lot. You could go in the other direction if you have a diarrhea, a lot of pooping. Maybe you're urinating a lot. Anyway, any way that you are losing volume in your body, blood, water, etc., that can give you a low blood pressure. What will happen is, well, a couple of things will happen, but we'll talk about in the kidneys with the juxtaglomerular system. The kidneys will notice, hey, there's a decrease in pressure coming in. So the kidneys will release renin. Renin will activate this inactive angiotensinogen, and it will cleave it to activate it to become more active to angiotensin 1. And we've talked about inactive and active molecules before when we did fibrinogen, fibrin, prothrombin, and thrombin, so you are familiar with this. So renin can do the same thing here, cleave the angiotensinogen to angiotensin 1. Then ACE is released from the lungs. We got another system in here now from the kidneys to the lungs. Angiotensin converting enzyme, that's what ACE means, will change angiotensin 1 to something even more active, angiotensin 2. Now we're going to another organ, the adrenal gland, but we're going to the cortex of the adrenal gland to get aldosterone. Anytime you say aldosterone, I want you to think about sodium. We're going to increase the retention of sodium in the body. When you increase sodium in the body or retention of sodium, what will happen? You're going to increase volume, and if you increase volume, you're going to increase the blood pressure. So, in cases of low blood pressure, say you're Mike Tyson and you've been fighting rounds, bouts, you got to like the 9th or 10th round, you have lost a tremendous amount of sweat or water due to sweat. Your blood pressure could be low. If you are playing soccer like Pele or Beckham, you can lose a lot of fluids that way, right? So your blood pressure could be low. What you need to do, of course, you can rehydrate. That's what Gatorade is for. And you can get your blood pressure back up. You just need to get your volume back up. But if you don't have access to that, and this is maybe a system where maybe a person's hemorrhaging, then the kidneys will detect that the pressure is low, will release renin, activate this old clunky inactive molecule angiotensinogen to angiotensin 1. The lungs will release angiotensin converting enzyme, convert angiotensin 1 into angiotensin 2. Then the adrenal gland in the cortical region of the adrenal gland will release aldosterone. Aldosterone will retain sodium in the blood, which will invariably increase your volume, and then the blood pressure would increase. I want to bring up one point. If this were opposite and this system was not detecting a low blood pressure, just say what we use ACE for, or we use ACE inhibitors. This is for high blood pressure. So we would stop this ACE from converting angiotensin 1 to angiotensin 2. We would use an ACE inhibitor in case of high blood pressure. And we would not allow the system to go on to, of course, increase sodium, increase volume, to increase blood pressure, because that would be not good for a person that already has high blood pressure. So this is where we looked at this system and go, how can we reverse this if it is already high blood pressure? Well, we can get an ACE inhibitor and prevent that. So really, I think that is the main thing. Make sure you know words like hypercapnia, which means an increase in carbon dioxide. Make sure you remember that baroreceptors have to do with pressure. Chemoreceptors have to do with chemistry, like the carbon dioxide, the oxygen, the pH. And I think for the most part, that will do it. I want you to remember these words too. ADH has to do with anti-diuretic hormone. And then ANH has to do with atrial natriuretic hormone. ADH is along with, I guess you could say it would be in this system. So it's anti-diuretic hormone against diuresing, against peeing, against urinating. This is released. It's the most vasopressive hormone that we have. It will constrict blood vessels. It will not even let you make a tear. It will hold on to every drop of fluid that you have if the body detects a low blood pressure. So it can actually hook up with this same system when the blood pressure is low. You won't even be able to make saliva when an antidiuretic hormone kicks in. It's going to take all the fluid in your body to get your blood pressure up. So if this is going to be coming from like the brain, so the brain, the kidneys, the lungs, the adrenal gland, all of that is going to be incorporated in when the body detects a low blood pressure. On the other hand, the antithesis of when you have a low blood pressure, this whole system kicks in, and this atrial natriuretic hormone, ANH, is when you have too much volume. The atria kind of bulge out, like in the heart, the top part, the atria bulge out, like, why is all this fluid coming in? Oh my gosh. This system does make you urinate. It makes you pee off the excess fluid so that your blood pressure and your volume will go down. So this is if you have a low blood pressure, you're gonna not urinate so you can hold on to volume. This is if you have a high blood pressure, your atria are bulging because so much fluid is coming in, so much blood, and it's gonna cause you to urinate so that you can get rid of the volume. So these two are antithesis of each other, and I just wanted to bring those up. Although we'll go over them more, as well as this system. We'll go over it again when we do the kidney. But it's good to introduce it now because it's, the body is all one, it goes together. This one, atrial natriuretic hormone, so much volume, the atria just bulging out, and it says, hey, we need to let you get rid of some of that. Maybe the person was transfused one too many times. Maybe the nurse didn't chart, oh, I transfused Mr. Jones earlier. Well, next nurse comes in and says, oh, Mr. Jones didn't get transfused. Well, she forgot to write it on the chart, so you transfuse again. Now you have so much volume. The atrial natriuretic hormone, this bulging out of the atria. They're like, oh, you need to get rid of that fluid. We're going to make you diurese. We're going to make you pee. Get rid of some fluid so that you can get back to a normal pressure. So that's it. Just wanted to bring those two up. And that will conclude the lecture on the cardiovascular system. It's a big section. We got through it though. So we'll be going next to lymphatics and respiratory. But that concludes the cardiovascular system.